Okay, so we'll note that when you've joined the meeting today, your cameras would have been turned off and your microphones would have been muted. And there will be opportunities to ask questions at the end of the session. And there is a Q&A section as well if anyone wants to put any questions in there. And I know that they will be pausing at the end. So welcome everybody today to this session. It is going to be quite an emotive topic we're talking about today. I recognise that everybody's incredibly busy at the moment, and obviously lots of things going on. So just want to give you the general health warning to make sure that everyone is okay, keep yourself safe, and access any support if you need any. Sometimes it's not the right time to be sitting in a session. If you've got a lot going on, if it's really particularly emotive for you today, just look after yourself and make sure that you access support that is available to you. We've got a number of colleagues here today that are going to talk through the presentation. So I'm going to introduce you now to Louise Danaher, who is from Healthwatch, who's going to talk to you about a piece of research and a document that's been produced through Healthwatch Surrey. So I'm going to hand over to you now, Louise, if you want to share your presentation.
Thank you. I will share my screen. Thank you. Okay, can you just confirm that you can see that okay?
Yeah, got that.
Set up. Lovely, brilliant. Okay, thank you. Well, thank you very much for coming on to the seminar this afternoon and for giving your time to listen to this presentation. As Dana has said, I'm Lou Danaher. I am from Healthwatch Surrey. I just wanted to say a little bit about Healthwatch before I start, so that you're clear about where this organisation fits in the health network. But Healthwatch Surrey is part of a national network, and our role is to listen to the voices of people in Healthwatch Surrey's case in Surrey, across the county, to understand their experiences of both health and social care. So obviously we're talking about NHS health, and I start this presentation actually with a quote which I think sums up really Healthwatch's USP, which is to repeat verbatim what it is that people say to us. So we are concerned with qualitative research, and we attempt where possible to feed back the exact words that people have said to us to health service providers. And we actually have statutory responsibilities as an organisation to do just that. And the organisations that we present our findings to also have a statutory obligation to respond. So this quote here sums up that USP. When you ring the GP, you have to talk to the receptionist first, and they don't know about domestic abuse and how to deal with it. When I first got help, I spoke to 10 different doctors over 16 appointments and had to tell my story each time. No one knew where to signpost me. I was told I looked nice, so people didn't believe me. So the other reason I include this quote is because I feel it sums up many of the issues that we came across when we were carrying out this piece of research. So the research is called, or the report that has been written as a result of the research is called In Safe Hands, and it's focusing on access and experience of GP practice for people experiencing domestic abuse. So just to provide a bit of context, first of all, I'm sure you're all aware of the definition for domestic abuse. This is directly from the Domestic Abuse Act 2021. Any incident or pattern of incidents of controlling, coercive, threatening behaviour, violence or abuse between those aged 16 or over who are or have been intimate partners or family members regardless of gender or sexuality. And the reason why I think it's important to spend a little bit of time just looking at that definition is we felt it important to unpack it when carrying out this research, because the one thing we were hearing was a recognition of the obvious signs of domestic abuse, so broken bones and bruises, but less awareness of the less obvious signs of domestic abuse, so the coercive behaviour and controlling behaviour, financial and economic abuse, isolating people and estranging people from family and friends. I think it's also important to recognise that this definition talks about intimate partners or family members, regardless of gender or sexuality. So we're concerned here with relationships, men, women, adults or children, gay or straight, but also relationships that can exist outside of the home. So not just in the home, but outside of the home, any intimate relationship. Okay, so why did we do this research? So to answer that question, I'm sharing some statistics here. I'm sure most of you are aware that the incidence of domestic abuse during COVID rose significantly and have continued to rise exponentially since that point. And these statistics really illustrate that. So as you can see, within the UK, 2.1 million people aged 16 years and over experienced domestic abuse in the year ending March 2023, which is roughly 500 adults. And in Surrey, we have a statistic here about the use of the domestic abuse helpline, so up by 24% from the previous year. We also know that people experiencing domestic abuse are a priority population within the Surrey Health and Wellbeing Strategy, and are included in the strategy because they can expect to experience poor health outcomes, so therefore are a priority for us to focus on to understand what those issues might be. And as an organisation, whilst we'd spoken to people experiencing domestic abuse, we hadn't spoken to them specifically about their access and experience of healthcare. And finally, we found there to be a lack of data on domestic abuse from within GP practices. We also were asked specifically by South West Surrey Domestic Abuse to look at the low numbers of referrals coming from GP practices to their service. So later on in the report, you'll see that they quoted to us 0.1% of referrals in 2024 came from GP practices in Surrey, which they consider to be incredibly low, and wanted to understand the reasons for that. Okay, so in terms of our approach, the first thing we did was we spoke to the Surrey Domestic Abuse Partnership, and through them we were given access to DAC, and I'm pleased to say that Kerry from DAC is on the seminar with me today and we'll be taking questions at the end of the session. So DAC is an organisation that is made up of domestic abuse survivors within Surrey, and they worked with us to co-produce the research in terms of the methodology, so the survey and the structure for focus groups and interviews, and were there every step of the way, making sure that we were on track and we were being respectful and considerate of the survivors that we were working with. And we also spoke to Surrey Heartlands. So Dr. Tara Jones is on the call today, and Rebecca Eales, who is the nurse lead for safeguarding within Surrey Heartlands. Dr. Tara Jones is the clinical lead for adult safeguarding within Surrey Heartlands. And we work with them to get the GP perspective and input from our GP practices across Surrey. So in total, we were able to speak to 64 Surrey survivors, and we engaged in depth with 8 GP practices. So those GP practices were involved in a series of interviews, and in some cases, I actually went to visit the practices to look at their systems and processes for managing data relating to people experiencing domestic abuse. So what are the aims of our research? Well, we wanted to explore whether general practice was meeting the needs of people experiencing domestic abuse in Surrey and what improvements could be made to better those needs. So we wanted to know what the barriers were for people disclosing to their GP or a member of the GP practice team in the first place. We wanted to understand what would make it easier for someone to disclose to a member of their GP practice team. We wanted to try and get to the bottom of the issue I've already referred to around poor statistical numbers of referrals from GP practices to specialist services like Southwest Surrey domestic abuse. And we also wanted to understand overall what people's experiences were and get a clear picture of what it was that people experiencing domestic abuse had to say. So very simply put, we divided the research into the before, the during, and the after. So what are the problems in disclosing in the first place? What happens when somebody discloses? And finally, what's the follow-up once that disclosure is out in the arena? Okay, so moving on to barriers for disclosing domestic abuse. So this is the before, what stops people. And we were able to break down our barriers into what we called institutional factors and processes, and also survivor perceptions and beliefs. So let's look at these in turn. The first one, a lack of professional curiosity. So we found that GPs were not questioning the reason behind presentations, and there was a tendency to prescribe medication as the only solution. Before I go any further, I should say that clearly, whilst we spoke to 64 survivors, and 8 GP practices, they are only a percentage of the population. And we do recognise that we can only report on the data that we were given by those people that came forward. And some of those experiences actually related to the survivors' experience over time. So some were very recent, some were in the recent past. So I just want to couch that in terms of some of the points that I'm going to be making here. But going back to the lack of professional curiosity, the survey told us that 75% of people who completed the survey said that they had not been asked by their GP or another member of the GP practice team if they were experiencing domestic abuse or questions that might lead to disclosure. Interestingly, 77% said that if they had been asked, they would have chosen not to disclose at that time. And 53% said that they felt that they were attending their GP practice with reasons that they felt were related to their experience of domestic abuse. So, for example, with frequent ITUs, headaches, stomach aches, and those were not being picked up on as possible presentations for what was actually going on behind that particular issue that somebody was going with on that day. The BMJ produced a report back in 2019 that stated that 4 out of 5 patients visiting GP practices could be described as frequent attenders. And actually the description for frequent attenders is female, older, have more social and psychiatric problems, take more drugs for mental illness, have more medically unexplained symptoms and more long-term conditions. And actually that led us to a term that I certainly hadn't heard before, which was one described as problematizing by the survivors themselves. And it was where they were saying that their problem was seen. So, for example, a dependency on alcohol, but not actually the reasons for that problem. And that problem became what was seen throughout their care pathway from the moment it was diagnosed or recognized. And that was part of the whole understanding of what was meant by lack of professional curiosity. Appointment booking and confidentiality. We know that trying to get an appointment and being seen by the same GP or a preferred GP is a problem for everybody, and appointment times are limited, and in many GP practices there's still a request that somebody only visits with one presenting condition at a time. So this is something that is recognised by GPs just in the same way as survivors were saying this is an issue. They were recognising that it's not conducive to spending time with somebody and realizing that there actually might be something going on behind the scenes, because they're having to deal with what that presenting condition is at that moment in time. And equally for the survivor, it's not conducive to opening up and talking about what's going on because of those limited times. So we heard that a lack of confidential space and discretion from reception staff, concerns about the digital trail left on online booking systems, and a lack of timely and unhurried face-to-face appointments with a preferred GP were an issue for survivors. I'm just going to go back to that lack of confidential space and discretion from reception staff. We had a lot of concern about domestic abuse, people experiencing domestic abuse, not wanting to have to explain why they wanted to see their GP, and certainly not having to explain in a public arena like a reception space. We heard some really good examples of where reception staff were able to recognise that somebody had something that they wanted to say in a confidential manner and a confidential space, and they responded to people in that way. But we also had examples of where that wasn't happening. And there is ongoing concern also about online applications or online appointment systems where people experiencing domestic abuse certainly don't want to be saying why they want to see a GP in type. There's a lot of concern about the digital trail that potentially could leave. But at the same time, in order to get prioritised to be able to be seen through the triage system within GP practices, they were also saying somehow I have to communicate that this is important, it's a serious issue, and I need to be seen soon. So you can see how complex and difficult that particular issue is. Perceived lack of understanding. So there was a concern or underlying fear of not being believed and a perception of a lack of GP understanding of all forms of abuse. So just as I've described at the start of this presentation, survivors were saying, I'm not going with a broken bone and bruises. If I go and say that I'm being controlled in other ways, like financial control, are they going to believe me? It's my word against my perpetrator. In terms of our responses on our online survey, 41% said that they didn't feel that they would be believed. 41% also said that they were scared, and a further 50% said that they were concerned for their safety. Fear of authority was also something that came through, feelings of intimidation around GPs, with GPs being seen as in the same way as other people in authority, for example, the police or social workers. And actually some of that came from childhood experiences, even from teachers within school, and the concern that were they to disclose that these people, GPs, would have power and control over them. And actually, they were the ones that were concerned that they could potentially lose everything. If I open my mouth and I talk about this experience, am I going to lose my children? Am I going to lose my house? They have the power to make that happen. So there was a lot of concern about the authority and power that GPs might be able to wield. The perpetrator's presence, not being able to disclose with their perpetrator physically present or inhibited by their perpetrator being registered at a GP practice or with the same GP. I don't think there's any surprises about that at all, that obviously if the perpetrator is sat in the room, the person experiencing domestic abuse is not going to be able to speak, not going to be able to speak freely. Safe Later Lives report revealed some quite concerning data about those aged 65 and above presenting to their GPs with conditions that could be attributed to their age. So, for example, dementia and confusion, broken bones, but actually those being symptoms of being in an abusive relationship and with their partner or carer in tow. It was very easy for the perpetrator to be able to mask some of those presenting conditions as just being a result of being frail and elderly. I've got a quote just to share with you here. I was asked by a midwife at my Surrey GP with my husband in the room whether I have suffered or do suffer from abuse from my intimate partner. My response was shock, and my husband said, "Let's hope not, as you've just asked her in front of me." We spoke to some survivors who were actually experiencing domestic abuse from their children. They were one of the groups alongside men who were concerned that they wouldn't be believed because they were parents. How could their children be abusing them? And the men's main concern was, I'm seen as the perpetrator rather than the other way around. And trying to be believed would, I just don't feel I would be believed. This comment comes from somebody who was experiencing abuse from their child. My issues are about seeing doctors in relation to your child. I was repeatedly told that my husband had the right to be present because the child was his too, but this meant that I couldn't tell them what was going on as he was always there. I have got some audio quotes that I'd like to share with you. I'm hoping that the technology is going to work, but I think they are really impactful and sum up what I was saying earlier on, where we try as much as possible to record and repeat the actual words that survivors are sharing with us. So I'll just have a go at playing this one. Okay, so it's nice to end on a positive experience there. And as I said at the start, you know, we did have some mixed experiences, and it's nice to be able to showcase them all. All right, so this is where I may have a problem moving on, so just bear with me. Okay, I think it's okay now. So just to finish with the barriers, we had two relating to survivors' perceptions and beliefs, which were around generational and cultural issues. So beliefs that this is just a subject you do not discuss outside the home or potentially the church. So again, Safe Later Lives does recognise that generational and cultural attitudes towards marriage and relationships are potentially an issue for somebody disclosing, with the belief that what goes on in the home is private and that it's socially unacceptable to discuss matters outside the home. And it is exacerbated in particular for older Black and Asian minoritized ethnic women, and particularly from those with a religious background who face personal and familial pressures to stay with an abusive partner. And the last one was about people experiencing domestic abuse themselves not recognizing that that was the situation that they were in, and taking a significant time to realize that actually what I'm experiencing is domestic abuse and I can ask for some help and should be asking for some help. There are a couple of quotes there. We look for mental health issues, women's chronic pain, pelvic pain, recurring presentations, frequent attenders, drug and alcohol abuse, families with children with special needs. A big takeaway from the face-to-face training I did 18 months ago made me think about some of the more subtle ways in which people may be presenting. So that was the Surrey GP talking about some recent training they've been involved in. And I know Tara's going to be picking up on the training available to GPs a bit later in the presentation. And the box there is just sharing with you the statistics I shared with you earlier, excuse me. Just going to play this quote. Okay, so moving on to our experiences following disclosure or the decision to disclose. Survivors told us that following disclosure that their concerns once again were that they would not be believed, particularly if their abuse was non-physical or that they were a male or a parent. That they would be problematized or labeled, which I've already spoken about, with a specific medical condition or problem, and then treated for that problem and not supported to deal with the abuse. And finally, that members of the GP practice team did not have the domestic abuse knowledge to support them going forward and on occasion providing harmful and unsafe advice. We did have a couple of quotes that I'm just going to share with you here. And again, I would just like to put this in the context that survivors were talking to us about their whole survival experience. So some of these quotes aren't necessarily what we were hearing today, but nevertheless, the nurse told me that I should get out more, to go to the pub for a drink. For a nurse to prescribe that to someone who's experienced domestic abuse, that could be the exact environment where I've been hurt, or I could have a problem with alcohol because of the abuse. And this quote, my husband punched me in the stomach when I was pregnant because he wanted me to lose the baby. I rang up my GP because I was scared. I was starting to lose it. When I told the GP what had happened, he said, "What did you do to provoke him?" So I hung up the phone and called my social worker, who called the ambulance. Okay. So I'm going to move on now to look at what happens following disclosure. So this is specifically concerning signposting and referrals. And as you can see here, 68% of the respondents to our survey said that they were not signposted to specialist help from an independent domestic abuse and violence service once they'd shared their domestic abuse with a GP. And 89% said that they hadn't been referred. When we spoke to GPs were saying that it was difficult actually to encourage people to get help, to enable them to carry out a referral when they had just made a disclosure, was something that, as I've alluded to earlier on, was just too big a step, with concerns that I've mentioned about, well, what's going to happen to me? What do I stand to lose? Could I lose my children? Could I lose my home? And so on. So actually, even though signposting and referral potentially was happening, it was difficult to get people to take that step. Having said that, there was a very mixed experience we heard from GPs about what was common practice, with some GPs recognising that actually asking somebody to signpost when they're living quite chaotic and dangerous lives was actually just too big an ask in terms of their capacity to be able to do that. And the right way forward potentially could be referral. But we saw some great examples where GPs were saying, what we do is we take them into a room and we give them a private space, a consulting room, give them a private space. We'll either sit there with them if they want us to sit there when they're making a phone call, or we'll shut the door and leave them to it, but we will try and encourage them to pick up that phone there and then, whereas others were saying in some cases, actually, we don't really know what we can do. We don't know who to refer to or signpost to. So a really broad spectrum of experiences. Just to share another quote here. One of the things that one survivor said to us that they would like to have in place is proper signposting and support services, and it to be done quickly. So they were actually a rape victim, and they were saying referrals should be made quickly, if nothing else, because of the physical pain that this person was in. They said it took 8 months for me to get referred for a pelvic scan and repeated visits. They were also talking about the want to have some flagging system put on their records so that they didn't have to continue repeating their story over and over again. And that was something that we heard from survivors a lot. When we spoke to GPs about that system, one of the things we heard was a term called flaggate, where the GPs were saying, absolutely, we want the same, but actually there are so many flags now that come up for our patients. It's beginning to become difficult to prioritize and recognize what is most important in amongst all of those flags that pop up. One of our concerns that I mentioned earlier on was that when we spent time looking at records that were held on people experiencing domestic abuse, what we found was safeguarding records as opposed to specifically for domestic abuse survivors. But also what wasn't clear and wasn't being collected was the outcomes for those patients. So what had actually happened to them once they had made a disclosure, how frequently were they followed up, where had they gone in terms of support services, specialist support services and beyond. And again, it was mixed. For some individual GPs were very much on it and following up on a regular basis. For others, that wasn't happening. So it was quite a mixed experience. I'm just going to share this quote here. Okay, so here we've got a GP saying, I always refer people rather than signpost, but people decline as they don't want it on their record and they're worried that their perpetrator might find out. And I suspect that people are signposting when they should be referred. And then a survivor saying, when I went to see my GP, I was recognized as a victim and my perpetrator was named, but this was all I got. I wasn't referred to anyone else. GPs work in silos. It was the police who referred to me for help. But I don't think I had any expectation that the GP would do this. I would go to them for a sore throat or cold, but not for this. Okay, so what did we do then? So our next stage was to gather all those people that had contributed to the research. So those external stakeholder organisations that had given us access to domestic abuse survivors, representatives from Surrey Heartlands. We had the Surrey Police join us. We also had the Surrey Minority Ethnic Forum join us, amongst others, to get those people in the room to share the research that I've just shared with you. But the main aim was to collaboratively develop some pragmatic and practical solutions to improve access to support and experience of survivors. So our main concern was, okay, what are the tangibles that we can get out of this research and actually run with. I'm going to hand over to Tara in a second, but I'm pleased to say that the workshop was a success in that we had a lot of positive feedback about it on the day, and we did end up with a clear set of actions. And that's where I will hand over to Tara. She's going to take you through those remaining those outstanding actions that came from that workshop. So Tara, I'll keep going with the slides if that works for you.
That's lovely, Lou. Thank you. That's probably easier than switching backwards and forwards. So thank you. So for those who don't know me, just because a bit of background might be helpful here, I'm here in my role as designated GP for safeguarding, working across Surrey, a role I've been in since 2017. But I've been a GP working in East Surrey for 27 years. I was a partner for 20 years and continue to work as a sessional GP. So when Lou approached us to get involved with this work, I was approaching it very much both from my safeguarding role, but also as a GP. And some of what I'm about to go into tries to reflect both sides of that, because I think we had some really interesting conversations, as I think has been clear from what Lou's presented, about modern general practice, about some of the challenges, and actually what's achievable and what's sort of blue sky thinking and would be lovely, but perhaps isn't within our gift in a reasonable timescale. So that was a little bit of background to it. The other thing just to say, this talks very much about GPs, and I think we're all guilty of this as a sort of a shorthand these days, that actually when we're talking about GPs, we are talking about all of our staff working within modern general practice. I can see from the names on the calls, I recognise a lot of the names as both GP practice leads, but other colleagues from local practices. And one of the things that we've really tried to pick up within the learning from this is we are talking about a much different workforce in general practice to what we had sort of 20, 25 years ago. And that's been interesting in terms of looking at some of the things like training, for example, which I'll go into. And the final thing, just as a little bit of background before I go into the suggestions, was this was very much about GP practices, but I think we talked very much within the workshop and at our subsequent meetings that a lot of this is applicable both to other healthcare settings, but actually also places where survivors are accessing public services elsewhere. So I don't think any of this sits in isolation as just being about general practice. So since the workshop back in May, we've had a number of ongoing meetings with our outreach providers and with Lou and Kerry to try and move some of these actions forward. And I thought it would be helpful just to tell you a little bit about what some of the suggestions were that came up, where we've got to, and both where we've had some challenges, some quite interesting conversations about actually, is this really what we are working towards? Is this the right outcome? And somewhere there's already been some really positive outcomes. So I'll take you through those. So Lou's broken them down in terms of what had come up during the report. So the first one around that was around barriers to disclosure. The first suggestion that came up here was the idea of developing a Trojan horse, which is a sort of an ability to disclose without disclosing overtly, or to flag, there is something else going on here. We've had probably some of our most interesting conversations as groups following on from this aspect. Quite a lot of you will probably have heard of the Ask for Angela scheme, which is the hospitality industry scheme. There's a similar one which runs through various other environments, including community pharmacists. And it's been really interesting talking about this, because one of the things that came up is how quickly things like that become very apparent to perpetrators, and actually how quickly something that you're trying to promote as your ability to reach out and get help actually inadvertently can be flagging to your perpetrator that you're trying to get help. So we've had some really interesting conversations around that, and particularly around the fact, and I think Lou referenced this earlier, that for not all, but for quite a lot of survivors of domestic abuse, their perpetrator may still be living with them. Their perpetrator may well still be registered with the same GP practice. So there's that coexistence there between the survivor and the perpetrator in the same space. So we moved on a little bit actually from the Trojan horse in that sense to say, okay, what do we need to be doing to help identify that there may be a concern here? This also referenced Lou's earlier point about survivors themselves either not necessarily being at a point where they recognize what's happening to them in their relationship or feeling that they're ready to disclose. So we're looking again at those repeated presentations: pelvic pain, gynecological symptoms, urinary tract infections, mental health conditions, self-harming, hard to place symptoms, all of the things that we've already talked about. And one of the things we're looking at is doing a sort of a top 10. Actually, if somebody is presenting repeatedly with these things, think about asking the question, what some of you will know as targeted inquiry. So asking the question where someone's presentation actually makes you think that might be a factor. So we've moved a little bit away from the Trojan horse in what I think was initially meant with it as okay, how do we help? How do we help to identify both for our own staff, but also for the survivor themselves? So that's a piece of work that's still ongoing at the moment. The promoting the domestic abuse specialist, this has been great. I can see a number of our outreach colleagues are actually on the call with us today, which is really nice to see. We're looking at how do we really build up those relationships, and actually we've had some really positive input from the outreach teams to say actually what we'd like to do is we'd like to get into all of the practices on our patch and just go in and say, hello, this is who we are, you know, here are our leaflets, our stickers, our contact cards, putting a name to a face. So that's something that we're working with at the moment, and that's something that hopefully going into the early part of 2026 we'll be promoting out to the practices. We're also looking at an accreditation scheme, which, to paraphrase what's been used with some of our other accreditation services, is about what does a domestic abuse friendly GP practice look like. There's work ongoing around that because unlike some of the national accreditation schemes, there isn't a huge resource to put behind this. Those of you who are familiar, for example, with the breastfeeding friendly practice scheme, there's quite a lot that goes on behind the scenes with that. And the resource, unfortunately, just isn't there to be doing that degree of accreditation. But we are looking at things like, you know, what would it look like to recognise that you had a domestic abuse champion, that staff were aware of what the outreach services were locally and how to access them. So again, that's something that's work in progress, and we're hoping to have further developments with that going into the new year. So that's those bits. Experience following disclosure, the education and training, and I think this was referenced in one of the audio quotes that Lou brought up. So we cover a significant amount of domestic abuse training within our safeguarding training at level 3, but we're really mindful of the fact that the level 3 safeguarding training targets our clinicians in general practice. So it's our GPs, our nurses, our emergency nurse practitioners, our paramedic practitioners, our clinical pharmacists. You can go on, and you all know who you are and the roles that you've got. But where we don't have that reach, the safeguarding team is into the non-clinical teams. So one of the things we're working with our safeguarding leads and practice managers around is, what does that need to look like for our non-clinical staff who are very often that first point of contact? What knowledge do they need to have of the presentations of domestic abuse, and where do they fit in terms of that early, not necessarily recognition, because we are talking about non-clinical staff and the contact that they're having, but actually, could this be a factor? You know, where would I actually link someone to? And I'll come on in a minute to a little bit about our websites and how we can be using those. The same largely applies actually to about trauma-informed approaches. Again, for this level 3 safeguarding training that we run on a very regular basis, trauma-informed practice is really well embedded within that. However, we've still got that wider workforce to consider, and it's getting that message out across the whole workforce. And how do we do that when quite a lot of those staff groups are largely being trained and updated within the individual GP practices rather than on a more collective basis? We have an enormous general practice workforce in Surrey, and we have to be realistic about how every single staff member is accessing training and can keep up to date. And that's where our practice managers are really integral in this as well. In terms of health passports, people will be familiar with health passports for a number of conditions in terms of physical and psychological health conditions. It's something that was a piece of work that started even before this research was underway, and certainly our outreach providers are really looking at that. This is very much about survivors not having to retell their stories repeatedly. And we know from whole groups of patients, nobody wants to have to tell their story repeatedly, and people particularly don't want to share sensitive, emotional and emotive information more often than they need to. So that's something that's going on. And we're really committed to this idea of sharing best practice. One of the things that I think came out from the interviews that Lou undertook was there's some fantastic practice going on within our general practices. And because those of you who are GPs and GP practice staff know, however much we work together, we are individual GP practices. So it's trying to replicate that and encourage that learning from good practice and to get more consistency. Lou, can I have the next slide, please? Thanks. So moving on to suggestions from the workshop and the signposting and referrals bit. This was really interesting because I think a lot of people will be aware that signposting is something that's become much more prevalent and I think actively more encouraged for all sorts of services over the last few years. To reference, for example, adult talking therapist services, we actively now promote self-referral. So we will actively say, this is the link, go on this link, and this will take you through so you can self-refer yourself. And there's a lot of positives about that. There's no doubt about it at all. But I think what's become clear with domestic abuse services is when we're signposting, if we're signposting, first of all, we need to be actively following up. We need to be saying, actually, we did signpost, I'll see you back in a month's time, or at the very least, let me drop you a line, or, let me give you a call. Let's see where things are. Did you manage to make contact? If you didn't, why not? Okay, perhaps now isn't exactly the right moment for you, but let's keep in touch and see how things are going. So there's that follow-up after the signposting. And the other point, which Lou's already mentioned, is we have to recognise for a lot of survivors of domestic abuse, it becomes something else that needs tackling. It becomes something else. I've got to pick up the phone. I've got to find a day. I've got to find the time, the space to do that. And I really loved the idea of here, have this room, go and use the phone while you're here, strike while the iron's hot with that. So, it's a really simple thing that can be done to help with that. So we're certainly looking at that. In terms of the referral form, actually our outreach providers are 4 separate providers split geographically across the county. And the referral forms, although they are very similar, are all separate organisational referral forms. I think I referenced in one of our meetings, it would be just like if I was making a referral to, I'm in East Surrey, if I was making a referral to East Surrey Hospital, as opposed to Epsom Hospital. For the same condition, I would have 2 separate referral forms. But what we have confirmed is that the referral forms actually are very easily available and are now linked in for those of you who are not GPs or GP practices through our Ardens system. So the Ardens is our library of referral forms. So in just the same way as I can go to look for a cardiology referral form for a particular hospital, I can find the domestic abuse outreach referral form for my local service. So that's really made a big difference with that. They're also very straightforward referral forms. These are not lengthy forms. They are basic contact details, demographics, and, you know, can I contact this person safely? And how do I do that? So they're not onerous to complete. So we're really now trying to encourage, at least offer referral. We can't enforce a referral, obviously, but we can offer a referral if signposting isn't the right thing for that individual. I've already touched on the forging links with the outreach providers. Our outreach providers have told us that a lot of them actually have volunteer workers who are really well placed to do this, to go out to a practice, go and meet with some of the staff, you know, literally pop in at a lunchtime meeting, pop in at coffee time, go and introduce who they are, who the local service is, how do we contact them, and make sure that we've got the up-to-date toilet stickers and the other paper presentational bits that we need. So that's something that we're really hoping we're going to be able to roll out across our practices early into the new calendar year. And the directory of services, this was a great one because this was a really quick, straightforward win. We looked at what did we mean by a directory of services, and we actually realised that it was all already there on the Healthy Surrey website. So when Lou takes the slides back in a minute, I'm just going to post into the chat, and I'm sure we can put this link out as well. The link for our Healthy Surrey domestic abuse pages, which basically is our directory of services. It's got who are our outreach providers, which district and boroughs do they cover, how do I contact them in hours, how do I use a 24/7 contact if I need emergency contact details elsewhere, you know, what numbers can I give patients. Some of our more specialist groups who Lou has referenced as well, there's information about them as well. So we were really happy that we got our directory of services. And the final thing in terms of the signposting referrals bit is work that's ongoing around what do we have on our practice websites. So we've been working with the digital IT team at Surrey Heartlands around standardizing and improving that so that that information is really easily accessible. So if a patient goes onto our practice website and searches under domestic abuse, and we're looking at what other phrases people might search under, they'll get really clear information about who they can speak to and how they can actually access that advice. So all of that sort of very much work in progress, but work where I think there's been a considerable amount of progress. So we're looking basically to say, let's get as much consistency as we can. We know all of our practices are individual practices. We know everybody does things in certain ways, and we know that there isn't a one size fits all. But we want our response to be as consistent as it possibly can. And I think referencing the website message, that's really important so that actually anybody who's registered with a Surrey GP can get that same information really easily. We really want to make sure this is survivor led, and I think it's been all credit both to Healthwatch and to our outreach providers and the other agencies involved that this has been hugely survivor led, and Kerry has been very, very involved with that as well. And that is ongoing and is absolutely embedded within the work that we're doing. And my final point is it's maintaining momentum. I think at the moment when everybody is very busy, there's a lot of pressures across the system, as there always are, those don't go away, but it's making sure we keep this up. And I think I'm really pleased to say that 6 months after the workshop, I think that does continue, and I think we haven't lost momentum. So we're just really looking to get some of those things to a completion point. So I'll hand back over to you, Lou, for the last couple of slides now. Thank you.
Thanks, Tara. I'll just play the quote on this slide. Okay, so the last slide, these were the next steps immediately after the convening workshop, was to publish the research and share it widely. And I'm pleased to say we've done very well in achieving that. I think courtesy of Kerry, we've been able to get the report as high as the DA Commissioner's Office within government, which is fantastic news in terms of getting it out there. And attending forums such as this. So we're very grateful to have the opportunity to use this as a platform, and would very much appreciate your ongoing promotion of this. I'm sure the slides are going to be shared afterwards, and in a second, just as Tara's sharing information, I will also put a link in the chat to the full report for people that want to read it. There's also a summary of that report as well if you don't want to work your way through 70 pages, but there are various formats that you can do a bit of a deeper dive should you wish. So that actually brings us to the end of our presentation. I'll stop sharing and hopefully that's now gone, and we're very happy to answer any questions that you might have.
Thank you, Louise. Thank you, Tara. I just want to check. I can't see any questions in the Q&A section. I'm just double checking on the chat, but this is an opportunity if anybody wants to ask any direct questions, if they want to comment on the presentation today and the information provided by both Louise and Dr. Tara, please let us know. I can just see that Tara, you've just put a comment in. Do you want to come in there, Tara? Sorry, Dr.
Yeah,
Tara.
it was just a question about where on the Ardens template it is. I don't have the clinical system open in front of me to be able to double check that, and I don't want to misdirect. So I will check that and I can send that information out. Probably the best thing to do, because that's a specific GP practice thing, is I'll send that out through our network of practice safeguarding needs and practice managers. It means it will reach all of the practices as well. So leave that with me and I'll send something round about that. Thank you.
Perfect, thank you. And I can see that we've got a hand up, which might be Lucy. I think you should hopefully be able to unmute yourself now and ask the question. Have allowed your access. Look. There you go. Hopefully you might be able to unmute Lucy. Oh, it keeps remuting you. Let's just double check. Here it is. Just says Lucy on your, if you can't do unmute yourself, let's just have a look. I don't know if you want to add your question in the chat while I try and continue to do that. I can also see that
I've done it, sorry.
Yeah,
there we go.
Sorry,
well
I was
done,
pressing the wrong
worry.
bit. So thank you. It was really interesting. So it was nice to be part of this and fit it. Sorry, I'm looking at two screens. So I keep moving my head. And it was really encouraging to hear the things that have already been actioned, which is just brilliant. I had a lot of thoughts around a lot of the issues that were raised. One was, I'd be curious to know if you were to do this piece of work in a different area of Surrey, whether you would get the same kind of responses. And partly I'm thinking that because the two boroughs in Surrey have previously been part of the IRIS project and have received an awful lot of training and support, and it was across the whole practices. So it was all staff, clinicians and non-clinical staff. And I would hope that therefore a lot of the findings in those areas might be different, but yeah, be interested to know. And I guess just lots of odd little questions and thoughts I've had about a lot of the different points that were raised, particularly about making referrals and it being a big step. And, you know, there are ways of doing that with support from other agencies, maybe offering to meet with your patient in a room in the practice with another worker. So maybe somebody from an outreach service, or maybe somebody from somewhere else, but and another maybe GPMs or something like that, but that we could support in the background. There are lots of different ways of approaching it to make it easier for people to build up trust. Generally, having kind of worked in that way before, a lot of our referrals from GPs, the reason they did self-refer was because the GP had suggested it. So there's a lot of trust there and a lot of belief there. So you're in a really powerful position to do that. And an awful lot of the comments that you received from the survivors are all things that I would have hoped and prayed would have been addressed if they'd had access to the training. Because, how to ask questions, what to recognise, the fact that a lot of survivors don't walk in saying, I'm experiencing DA, that either they don't recognise it or they're too worried to say that. And yes, saying things in front of the perpetrator, that kind of thing, and ways of managing that. And I've got a masses, but one simple thing maybe just to mention is when we were providing this IRIS role, one of the key strengths of it was that there was a clinical lead within the boroughs. So that's a GP that had a particular interest and strength around domestic abuse. And I'm just wondering if there's some way, I'm guessing that was funded because of IRIS-I, but maybe there's another way to look at having that person that could be a resource across Surrey, maybe in the same way that Tara is for safeguarding. The loss of the IRIS and the loss of the HIDFAs in the hospitals will have had a big impact as well, I think. So yeah, a lot of the things that were raised, I just feel were addressed in the systems that we sadly no longer have funding for. So yeah, I'll leave it there because I could go on forever.
I think it's one of the first things that, Tara, when we first met you, were lamenting the fact that those resources had gone. I think it is important, though, just to say that the research was conducted right across Surrey. So it's not a part of Surrey, it is Surrey wide. So we made sure that we did take that full county approach. But Tara, do you want to answer the question, respond to any of the questions about how to support people with referrals?
I'm trying to remember everything, Lucy, but do jump back in because I probably won't. Yes, certainly. I actually was clinical lead for IRIS in East Surrey, declaring an interest. It was a fantastic system, and we were heartbroken in the district and boroughs who it covered to have lost funding for it. One of the real frustrations, speaking candidly, is a lot of what we're now trying to do is effectively what IRIS was without the funding for IRIS. And I don't think anyone in the room will need it saying that is very, very difficult. There's a reason why the IRIS approach costs what it does, which is not a lot, but there is a cost associated with it. And effectively now some of what we're trying to replicate is the same without the money there. And you referenced the hospital IDVAs as well, and I think we would agree with that. I think going back to the training aspect, absolutely. I think this references again what we talked about, which we are talking about a much more diverse clinical group, never mind non-clinical group, to perhaps where we were even 10, maybe even 5 years ago. So we've got staff who come from very different professional backgrounds. Their background and training is different, and it's looking at that standardization. But if you are working in a clinical role in general practice anywhere in the country, this isn't a Surrey thing, you will be level 3 safeguarding trained, and domestic abuse training is an integral part of that safeguarding training. So that is absolutely embedded. There's a question which we'll pick up in a minute in the Q&A, which I think is around the non-clinical staff as well. So I'll come back across to that. And then in terms of linking in, absolutely, Lucy, we totally agree with you, and we know that in general practice, we're big teams. We work with large numbers of different staff. We have staff who come into the practice who aren't directly employed, for example, like social prescribers, and we're, I think, well used to sort of saying, okay, maybe this person doesn't want to tell me as the GP about this, but I've got a sense there's something else going on. So I'm going to link in with the GPM service if it's mental health, the social prescriber if it feels more of a non-direct healthcare issue, and making sure those people as well actually are really aware of how to access the help. I wouldn't want to see us lose signposting. I think signposting is really important for quite a lot of survivors and for quite a lot of services. But I think if we are signposting it, saying, are we following up on that? And are we offering the choice for us to make a referral? And I think that was everything, but tell me if I missed anything working backwards there.
Yeah, no, I think that is all I raised. And I just think a lot of the comments that were made by survivors would have been addressed, would have been prevented if the training had been available and accessed. And I appreciate that maybe all the staff change frequently in practices. So even those that had training in the past, there may be new people in there now. And maybe the bigger question is, why don't they get this training earlier, like in medical school, or, so that it's more widely understood earlier. I mean, there's lots of, but yeah, no, thanks, Tara.
Thanks, Lucy.
Thanks, Lucy. And again, Lucy, if there's any more points you wanted to add in the Q&A section that hasn't been covered, then please do so, because we do want to capture everyone's thoughts on the session. I can see in the Q&A there were some other questions. Is that what you were alluding to, Tara? So there was one from Mark, which was about GPs required to undertake a module on dealing with DA as part of their qualification registration requirements. And then there was a second one around, is there a resource to help train and support reception staff? So I don't know if you want to answer those, Tara, or...
Yeah, I'm happy to take those. Mark, so the question, Mark's question's a really interesting one, because again, I think this references quite a lot of the issues we've discussed around training. So is it mandatory to undertake domestic abuse training? No, it isn't, but domestic abuse training is embedded within all of the safeguarding training, and that's true both for what we deliver locally and what's delivered across the various sort of national packages which are available. To take you through specifically on the GPs, but this is just specifically for the GPs, at the point that the GP training scheme, so as GPs are coming through their training to be fully qualified GPs, they have to be signed off for their safeguarding training as part of their registration as a GP. I think overlapping, Lucy, with your question, part of this about doing it early on is about the sheer range of different backgrounds that people are coming from. I'm a GP, I train the GP registrars, but actually I'm not involved in undergraduate nurse education, paramedic education, before we even get to the non-clinical staff and how they're trained. So we are talking about, actually, if we're talking about undergraduate training, for example, a very, very wide range of disciplines, the majority of who I have no direct input with, and clearly that needs to be a national directive, because that's what's actually included in undergraduate training. We've also obviously got considerable staff members who will not have been through a graduate training program. So it's thinking about how does that get out there as widely as possible. That overlaps then, I think, sorry, I have just clicked on the wrong thing and lost the question there. That then overlaps with the question about training and support for reception staff. So yes, there are, and there's a number of the modules which actually sit through the Blue Stream. For those of you who aren't from GP practices, Blue Stream is the sort of training library for a whole range of training required across our GP staff, but that's very generic, it's not localized. We are looking through what we're doing with the outreach providers about how do we not do training, because again, going back to the comment about Iris, there isn't the funding there to go into every GP practice and actually deliver that training to all the non-clinical staff. But how do we skill up, I think, our frontline non-clinical staff with that knowledge around our outreach services, and how to be domestic abuse aware. So I think we are contending with the resource battle, and being realistic about what we can actually do. And realistically, there isn't a resource to go in and deliver training to all non-clinical staff in the 110 plus Surrey GP practices. but there are ways we can support and facilitate with that. And the other thing that's coming up at the moment, which is a national initiative, which is the NHS England mandatory and statutory learning suite, which will have the newly updated safeguarding training and domestic abuse training within that. So there are a number of resources there, but we're really keen to give that local information as well, because I think that's far more valuable than generic training.
Dr. Tara, I think it looks like Kerry's desperately trying to jump in there
Sorry,
as well
I
to come up with something, don't
No,
worry.
it's fine.
In the least, Kerry, I do apologise. I'll shut up.
No, it's fine. I was just going to say it's not GP training specific, but on the Healthy Surrey website, which Tara has put in, Surrey County Council provide a wealth of free domestic abuse related training for anyone who works within Surrey. Now, obviously, it's quite basic, it's not highly specialized, but there's 3 levels of domestic abuse training. There's training on how to work with children and young people, there's training on stalking and harassment, coercive and controlling behavior. So it's a good basic start and it's free, so please make use of those resources, and those sessions are provided with all sorts of other agencies. So you'll be on a course with social workers, people from all sorts of health services and other backgrounds. So it gives you a very well-rounded view, particularly if you're on a reception desk and you're coming into contact with people and you don't know what other services are around. It gives you a very good insight, I guess, into what's going on within Surrey and who else works with survivors.
Thank you, Kerry, and thank you. Sorry, I didn't mean to shut you down then, Dr. Tara. I thought that was really important. And we've actually included the link again directly to the training, because there is a lot on there, and it is that real sort of multi-purpose, multi-agency discussion, which is really helpful, I think, in those meetings as well. Let me have a. Oh, so we've got another hand up. Oh, Lucy. Back to you.
Me again, sorry. Yeah,
No,
just a
don't worry.
simple thought really, following on from that about the training, is that because previously I had the role that was providing the training, I did get invited into various different kind of health groups to provide a session on it. And more recently, and that's actually been in conferences and things that different health groups are having anyway. So just to, bear that in mind, to invite and think about having one of your sessions as DA from your local DA service, wherever that might be within Surrey, because that might be a way to start developing those links more strongly as well. And if they're there anyway and they're getting their, their CPD and everything by being at the conference or the training, because fitting it in, I appreciate, is really difficult in busy working times and releasing people for training. But if it's something they're at anyway, if there's priority for there always being a DA input on it, that will just gradually hopefully help. And if the receptionist staff are really on the ball, they will feed information into the clinicians. It'll work. It'll just improve everybody. Just a thought.
Thank you, Lucy. No, absolutely, really good thought, that one. Thank you. Kerry, Dr. Tara, did you want to respond to any of that before? We have got one more question, I think, for the looks.
All I was going to say, Lucy, was absolutely, we've had DA outreach included in a number of our large-scale primary practice learning events, which are the sessions when the practices close, usually for an afternoon for training, and that's been really valuable. One of the things we've just been respectful of with the outreach providers is your capacity as well, because we would love nothing more than to say, actually, every practice manager, here's your contact, and ask someone to come in and do a training session. But that takes a lot of resource on your part as well, which is where the sort of at least initial linkage perhaps makes it a little bit more manageable and a bit more staggered, so you're not getting dozens of requests all in one go. So yeah, that was my only sort of feed in there. Kerry, I didn't know if you wanted to come in there from the survivor side of things.
I think the way I think of it, and this is going to be a bit of a odd analogy to start with, so bear with me, but I tend to think, so I used to love archaeology growing up, and I tend to think that working with survivors is a bit like going into archaeology, because every service that a survivor comes into contact with will uncover a little bit of the ruins that they're left with. But specialist DA outreach, you have to think of them as the professors in the field, because they will know more about a survivor than any other service does in silo. And because we know that there's a lot of silo working and it's difficult to information share and things like that, this is where DA outreach comes into its own. I don't know if you would agree with that, Lucy. So, you know, with regard to training in that, we can only say no. It's always worth asking. If we haven't got capacity, we'll let you know. But yeah, always ask, I think, because keeping lived experience, having led DA scene for 5 years nearly now, keeping survivors at the heart of what you do is so important, because quite often what people think we need is actually very different to what we think and know that we need, and that disconnect can be quite marked. And it's really important, I think, just to keep survivors front and centre in training and what you do.
Yeah, and I would just to add that, I mean, if it's not just a single practice, but it's a group of practices, which is quite often what I've been invited to do recently, you're reaching a lot of people. So we would give you that half a day or whatever, because we're reaching so many in one go. That's a good use of our time, I think. And we would try to meet that need.
Lovely, thank you, ladies. Joe, I can see you've got your hand up. Hopefully you should be able to unmute and ask a question now if you want to. Got your hands up. The joys of technology. So it says Joe from SWSDAS. We love a good acronym. I think that may be Southwest Domestic. Oh, can't unmute. Let me see if I can try and do it again. Hello, Mike. Try it again now, Joe. It's technology at its best. If you're unable to unmute, you may want to just put it in the chat. I'm going to keep trying to unmute you. I can see that there was another question around Becky, sorry, put a question here around the mention of volunteers going into GPs with toilet stickers to have a chat. How would an organisation go about doing this? Is it just a case of turning up, or is there a booking system? I'm not sure if anyone's aware of how that process works.
I'm assuming that's about, sorry, Becky, and I would say unmute yourself, but that might not work well, given we've had a slightly patchy success with that. I'm reading that as if you wanted someone to come in and do that, how would you go about it? But it might be that it's coming from, if I'm the organisation and I want to do that. I don't know if you just want to, if you can't unmute, if you just want to put in the chat so that we're clear which side of that the question is coming from. That's okay. And it looks like Joe's struggling to unmute.
Yeah, I've tried. It's saying from my end that you should be able to unmute yourself now, Joe, but I can see that you have put in a question. So you've said that as a trainer for the Southwest Surrey, I'm happy to come along to train any group of clinical professionals in my area, which is Guildford and Waverley. Please just call our service if you want leaflets delivered. And then I think that was it. Yes, so thank you very much, Joe. That was very badly spoken of me then, but I can see another offer of help, which is great, because I know that everyone's incredibly busy. But like you say, if we can get out and share that information as much as possible, that's great. And Joe, you said you do have volunteers that can also deliver, which is great. Becky, you've come back. If I'm the organisation, could we do that? I'm working for the organisation.
Okay,
So
no, that makes sense. Thank you, Becky. I wasn't quite sure. So for an organisation, you can absolutely always contact a local practice, and a lot of our third sector and voluntary organisations do that on a regular basis for all sorts of things. However, what we're looking at on a slightly more structured basis is to put that offer out, to actually going out to our practices saying, here is your contact detail if you would like someone to come in and actually do an initial meeting with staff and bring in leaflets, toilet stickers. This is how you know, this is how you make contact. So it could be from either end. It obviously needs a little bit of organisation for the right person to be there to actually, you know, meet and greet. But yeah, that's what we're planning to do. It will be obviously the other side of Christmas and New Year now, because nobody has got the capacity to be doing this in the last few weeks before the Christmas break. But that's trying to get that link in, and the offers as the linkages from the outreach services are hugely valued. And just to reassure, because I don't think we've got all 4 outreach providers here today, and apologies I can't see all of the names, but all 4 outreach providers are working really, really closely with us with that, and are doing absolutely everything they can to support with that offer. So just want to acknowledge that huge amount of work that's gone into that.
Thank you. Thank you for that. I'm just wondering, Kerry, did you have anything else to add there? No. Louise, did you want to add anything further?
No, I haven't got anything else to add. I just think it's really useful feedback and discussion that we can continue to be thinking about and taking on board. So thank you.
Thank you, everybody. I'm just looking to see if we've got any other questions. If there's any more questions, please feel free to put your hands up. You may not be able to be unmuted, but I'm sure we can work a way around it. There has been some really good questions and some really good comments, and that actual sort of reaching out of agencies to say that they're happy to come out and deliver some sessions is brilliant. So that's what it's all about. It's all about working together. So I think if we've got no more questions, I will thank everybody again. So thank you to Louise for all the hard work and bringing this along today to share with us. Thank you, Dr. Tara, for your engagement with that, and also Kerry for coming along and sharing that experience. So please, everyone, look after yourself. It's really difficult at the moment. Everyone's really busy. We are fast approaching the Christmas period, and there's lots of winter pressures. So make sure you all have a chance to have a brew and a quick step away from your devices, and look after yourself. But thank you so much for everyone to attend. But we will close the session, and just look after yourself. Take care.
Thanks all. Bye.
Thank you. Bye-bye.